Ladies and gentlemen, good morning. Still talking about valvular air disease, and now I will show you the Italian approach. First of all, I have nothing to disclose, and the content of this presentation is my own opinion, not necessarily reflecting the official point of view of the Italian Air Force, the Italian Ministry of Defense, Italian government. This is the agenda. I will show you some criteria for risk assessment. I will give you a general overview. Then I will discuss the criteria for aeromedical certification in Italy. And finally, I will give you a brief overview of some of the valves, with particularly attention to the tricuspid and pulmonary valves. Now is time to have a polling test. These are the questions. The first one is there any risk for flight safety intended as sudden incapacitation? It's running.
Is anyone having trouble with that clicker or? Okay.
Yes, clearly, yes. Is there any risk due to the exposure to the flight activity in terms of progression of the disease and the risk of medical certification denial? Okay, last one. Are there published data about the outcome of valvular air disease in air crews? Okay, thank you very much to everybody. Yes, there is concern for flight safety in terms of sudden incapacitation, but we have also to add to this topic the risk of interference of medical condition on conducting the mission. Is there risk due to flight duty, due to exposure to the flight duty? There are few works on this. Nothing regarding air crews. And the risk of medical certification denial from a cost effectiveness point of view, we have to have in mind this in the first visit mainly. There are few published data about the outcome of valvular disease in air crews. There are a lot of case reports, but no studies following a lot of subjects. This is about general overview. When we deal with valvular air disease, we have to take in mind the prevalence in asymptomatic adults, because it is expected that people with severe or symptomatic disease don't apply for an aeromedical certification. Some other things can orientate for the assessment of the fitness. For example, the risk of sudden incapacitation, the risk of worsening due to flight exposure, the incidence of arrhythmias, heart failure, cardiac hypertrophy, pulmonary hypertension. All these conditions can affect negatively both the sudden incapacitation, can increase the risk of sudden incapacitation and can affect the progression of the disease. Valvular disease and valvular abnormalities can be part of congenital heart disorder or cognitive tissue disorder. This is to be taken in mind because we have to consider the patient, the subject, all in these conditions. Is there a prevalence of comorbidity, for example, blood hypertension or lung diseases? And what about the risk of endocarditis? Talking about valve repair or valve replacement is to take in mind if a bioprosthesis or a mechanical prosthesis is placed. And it's also to be considered the freedom time from valve-related events and or valve deterioration. And if the subject is on anticoagulants or blood thinners or other medicaments. These are the criteria for the aeromedical certification for military air crews in Italy under the ministerial directive cited. At the first visit, stenosis or regurgitation of any grade are unfit. Mitral valve prolapse without regurgitation may be fit under conditions. Condition means that two-dimensional echocardiogram should be normal, cardiac stress test should be normal, and 24 hours ECG recording should be normal. And without limitations. At the renewal, low-grade stenosis or regurgitation may be fit under conditions and with limitation. Limitation may include shorter period certification or double pilot, another pilot on board. Valve repair may be fit under conditions 9 months after operation, without treatment and without sedation. Valve replacement by prosthesis may be fit under conditions 9 months after operation, and mechanical prostheses are always unfit. Anticoagulants, always unfit. This is under review at the moment. As you know, there is no differences, for example, between pilots or fast jet or transport pilot. We are introducing now a grading of the fitness assessment, considering pilot and air crews on fast jet, transport pilots, and other air crews. So the outcome should be mechanical prosthesis always unfit for everybody, and while bioprosthesis or valve repair may be fit for pilot, for transport pilot, without any treatment or without anticoagulants. This for civilian. We are still following this regulation for 2-3 weeks more, because starting from this year, starting from April, next April, we should have the new regulation from EASA. Briefly, significant valvular abnormalities are unfit. This is quite clear because clearly severe valvular abnormalities are unfit, mild may be fit, but what about moderate? Minor valvular abnormalities might be fit under conditions the same of the military and without limitations. Because aortic valve may be fit under conditions. Aortic stenosis with gradient less than 25 millimeters mercury may be fit under conditions. Aortic insufficiency is fit if not significant. Mitral stenosis always unfit. Mitral regurgitation might be fit in multi-crew operations if uncomplicated, but is fit in case of left ventricle enlargement. Valve repair fit under conditions. Valve replacement with bioprosthesis may be fit under conditions 9 months of operations. A mechanical valve is always unfit. Anticoagulants fits under conditions. Now it's changing, as I told. Biological and mechanical prostheses may be considered fit under in patient without medication, without symptoms, 6 months after the operations. For anticoagulation, it must be collected a 6-month assessment with 5 checks. 4 out of 5 should be normal, and all 5 should demonstrate stability of the ENR. These are what we do in terms of diagnostics. We start with medical examination by an aviation medical examiner. Clearly, this history is included. And the ECG pending on age, always for military air crews. On indication, there will be a consultant by a cardiologist, echocardiography at the first visit. We perform always at the first visit for military air crews. Exercise ECG, which is performed at first visit for military air crews, and every year for pilots over for jet pilots over 40 years of age. A 24 hours ECG, a 24 hours ambulatory pressure recording, chest X-ray, blood chemistry, lipids, glucose, renal function, liver function, and coronary angiography could may be requested after myocardial infarction, coronary artery bypass surgery, and coronary angioplasty. I did not mention other diagnostics exam. For example, MRI, CT scan, myocardial, perfusion scan. These are not included in our regulations, but we can ask for, we can request them, especially for military air crews. So we expect to have medical examination usually normal for mild for valvular air disease. The ECG is expected to be normal or aspecific. A medical examination by a cardiologist could give findings on murmurs, on other things. The echocardiography is most important. And usually we could have an exercise ECG normal, usually normal in aeromedical settings, a 24-hour ECG possibly abnormal, but it could be normal. A 24-hour ambulatory blood pressure recording usually normal also. Chest X-ray is poor. We have never seen cases of enlargement of the heart due to valvular disease in our practice. Blood chemistry is usually normal, so on coronary angiography has limited indications for the valvular disease. So I would ask you to give your support on this presentation, because I propose you two different approaches. On the left, we have a complete diagnostic protocol, which includes everything, not also in order to get a diagnosis, but also to assess the grade, the level of the pathology, of the disease, and maybe the indication for further treatment of a surgery. The advantage include an accurate diagnosis. It helps in avoiding controversies. We are concerned about this because discharging people maybe felt as something interfering with the right of getting a job. Disadvantages include high cost, it could be invasive. On the other hand, on the right, we have a minimal aeromedically guided assessment. We use the minimal diagnostic investigation in order to find some conditions in the requirements. When we find it, we take a decision from an aeromedical point of view, and no further assessment will be made. The advantage include cost saving, focus on the non-medical concern, no invasive. Disadvantage, less accurate, questionable. We could make a diagnosis, but we don't know anything more about the disease. So, all think that the left approach would be appropriate for the first visit. Please raise your hand. First visit. And who think that the right approach would be better for the first visit of an applicant to a medical certification? Few hands, but prevailing this latter opinion. This is the Italian approach, in fact. So at the first visit, we approach with minimally invasive diagnostics, while with pilots in service, either military or civilian, we ask for a complete assessment of the disease. Clearly, there is no correct answer on this. This is a choice. Briefly on this, because Joe showed us the left side and focusing on the right side of the heart. Tricuspid valve stenosis. This is a very rare condition. I've never seen any in 20 years. Most common rheumatic fever is the cause. Usually it's associated with mitral stenosis, often mild. No studies. There are no studies involving flight personnel. These are criteria for the severe form of tricuspid stenosis. So maybe all these criteria are based on echocardiography. Tricuspid valve regurgitation is most commonly this is the most common finding. The cause is the right ventricle enlargement, common in left-sided heart abnormalities, so we have to take in mind that there could be an association with other valvular defects. Usually mild and silent. Studies report that normal individuals' prevalence is variable from 24 to 96%, often associated with mitral regurgitation. Symptoms include ascites, hepatomegaly, edema. Patients with mild tricuspid regurgitation and normal heart have no restriction during their life, and restriction to sport is related mainly to pulmonary hypertension. This is very mild tricuspid regurgitation. This is quite bigger. This is just to show you, I don't know if it's readable, I apologize for this, just for show you the guidelines. These are the European guidelines. There are slight differences between the American guidelines and the European one. This is one of most cited studies on the impact of tricuspid regurgitation on long-term survival, showing that there is no differences, no significant difference between mild tricuspid regurgitation, and normal subjects. Pulmonary stenosis. The most common congenital. Other causes include rheumatic fever, carcinoid, may be asymptomatic, may present with cyanosis, faintings on exercise. The low oxygenation is one of pathophysiological aspects that we have to consider in an aeromedical settings. Echocardiography gives us a criteria for grading from mild to moderate to severe in order to get the mild, which is the form that we can assess as fitness to fly, the fit to fly. Pulmonary valvular regurgitation is mostly it is also common. The most common cause is dilation of valvular ring, endocarditis, carcinoid. Common finding of mild non-significant leakage at the echocardiogram. There are no studies on flight personnel. This is the valve, and this is the leakage, the central leakage. The central leakage is a criteria for good prognosis. Also, the European guidelines, this is the mild form. The jet should be usually less than 10 millimeters in length with a narrow origin at central part of the valve. So, to tend to answer the questions about the current approach in terms of aeromedical certification of valvular air disease, the risk for flight safety intended as sudden incapacitation mainly is acceptable if mild regurgitation or mild stenosis, considering also the limitation for pilots or a crew employed in fast jet or employed as special forces operators. But there should be a normal heart and no need for treatment. Apparently there is no risk due to the exposure to flight, but there is no study on this. Especially in Italy, we don't have a follow-up to people discharged from the first visit. So further investigation maybe should need this. This concludes my presentation, so thank you for your attention. So I'm interested.